Welcome to this podcast on pulmonary diffusion. This is going to be a very short podcast, probably only about 5 minutes. Okay, so the first thing that we have here is the structure of the alveolo-capillary membrane. And what this shows is that this area indicated in blue, and it's on both sides, is basically the alveolus. And this highlights, if you will, the structures that oxygen has to diffuse through as it goes from the alveolus into the red blood cell. It goes through the epithelium of the alveolus. It has to go through the cytoplasm. It's got the fused basement membrane. It's got the endothelium of the blood vessel. It has to enter the plasma, and then from the plasma it has to enter into the red blood cell. All those things then would be considered as constituting part of the alveolo-capillary membrane. This graph shows, based on time, the amount of time that it takes for oxygen to diffuse into the blood to achieve basically a normal PO2. So what you see is that in normal circumstances, it takes about a quarter of a second to have the blood in this curve, which is a normal curve, such that the PO2 in that pulmonary capillary blood is essentially the same as the PO2 in the alveolus. Okay. Under circumstances of increased cardiac output, such as occurs with exercise, the amount of time that the blood spends in the lung unit is less. It can become as little as, instead of 0.75 seconds, which is what normally occurs under normal circumstances, it can be as little as 0.25 seconds. So again, what this shows is that in the circumstance of a normal situation, blood spends this much time in the pulmonary capillary, but it's actually completely oxygenated at about this point in time. But under circumstances of exercise or increased cardiac output, when the cardiac output is tripled, in that circumstance, then the amount of time that the blood spends in the pulmonary capillary may be as little as a fourth of a second. And so you may actually, at that point in time, not have gotten to the same value. The pulmonary capillary blood will not have the same PO2 as the alveolus does. And that occurs because in this circumstance, perfusion is so high that the diffusion of oxygen from the alveolus into the pulmonary capillary blood is slow enough that there's some limitation of oxygen uptake by the pulmonary capillary blood as a result of this circumstance. But that's, again, basically, in order to see that, you have to have a cardiac output that is triple what normal is. That's all well and good, and people talk about this, the problem of diffusion block in patients with pulmonary fibrosis or other problems. But in reality, what happens is that there's a driving pressure that moves oxygen from the alveolus into the blood. And if you look at a patient who's on room air, the alveolar PO2 is somewhere in the vicinity of 100. And we know that a normal mixed venous PO2 is about 40. So the driving pressure that exists here on room air is about 60 millimeters of mercury. But if you stop and think about this, if all you do is put the patient on 30% oxygen, that driving pressure has gone from 60 to 120 millimeters of mercury. What that means is that while it's hypothetically possible for some problem with diffusion to create hypoxemia in patients on room air. Once you put the patient on as little as 30% oxygen, they're not going to be hypoxemic because the driving pressure is so high that it's able to overcome whatever barrier there may happen to be to the diffusion of oxygen. Now, again, the patient won't necessarily have a normal arterial PO2, but it's still going to be such that they're not going to be hypoxic. Since essentially all of the time in the operating room, and for that matter in the ICU, the patients are on 30% oxygen or more, diffusion block is not really a consideration in terms of evaluating the patient for hypoxemia. It just isn't a real issue because it's overwhelmed by the increase in inspired oxygen concentration. Thank you very much for your attention, and have a good day.